Namaskar. Namaskar. Let us learn pedigree drawing and interpretation today. When we think of a pedigree, it's a diagrammatic representation of relations between the family members and then of their disease status. So our philosophy say always the question is, who am I, where I have come from? Kastam koham kuta ayataha kame janani kome tataha. But for a geneticist, it is important really to find out who you are, who are your relatives, and this is important to identify possible carriers of the disease or possible mode of inheritance. These are various symbols. Most of you would know that square is for a man and a circle is for a female. And then there are relationship lines, horizontal lines and vertical lines showing marriages and the relation between next generation. The individual who has a disorder and brings the family to notice is called a proband and is denoted by a arrow and remarked by P. Spontaneous abortions are triangles. If the spontaneous aborted fetus had some disorder, birth defect, it is shaded. If you terminate because of prenatal diagnosis of malformation, this is the sign where the triangle is shaded and then it is marked by the crossing line. So these symbols, once you know about twins, then about other adoption, and now with assisted reproductive techniques, you have to know the symbols for donor sperms, donor ova, etc. So this is a family, hypothetical family of Chanda who is pregnant. You can take a screenshot of this and then try to draw this pedigree after some time to get an experience. This is the picture of the really pedigree, what I had talked about Chanda and her husband. So when you draw, you can check your pedigree with this particular diagram. When we draw pedigree, the important first thing we want to find out how many people are affected and what are their relations and what could be the mode of inheritance. So this is a typical autosomal dominant mode of inheritance where multiple members over different generations are affected, but their severity of malformations or severity of the disease may vary from individual to individual, and this variable type of expression is a characteristic of autosomal dominant inheritance. In the other pedigree, you can see the first individual from the first pedigree, first generation, and third individual from the third generation are having the disease, but the in between, the mother of this particular person is unaffected, but she should be carrying the disease causing gene. That's why she had transmitted the disease to her son, that is the third person in the third generation. And such type of thing is called as non-penetrance, or some diseases where such type of thing is seen that over generations you can see some individuals who do not have a disease but they have a mutated copy of the gene and they pass on the disease to the next generation, and this is called as incomplete penetrance, which is also a characteristic of some genetic disorders. The other way of this incomplete penetrance is age-related penetrance, and you can see in Huntington chorea the age of presentation of various affected members in the family may vary, and it sometimes is seen to decrease with generation, as you can see in this particular family, where the age of presentation were decreased over generations. And then naturally, if the sister of this particular proband a second individual in the third generation, whether she can have a child with Huntington chorea or whether she will develop this particular disease. You cannot be sure because she may develop the disease before 30 or even at later age. And hence, these informations, once you know, you can use in genetic counseling or interpretation of the results or pedigree data accurately. The recurrence of risk of recurrence also we have to give based on the mode of inheritance. This type of trident appearance is a hand appearance is a characteristic of achondroplasia, which is an autosomal dominant disease. The penetrance is complete and the presentation is severity is always similar. So if one of the partners is affected with the disease and is having a capital D or mutated copy of the gene, then his or her 50% of the offspring can have that particular mutated copy of the gene and can have a disease or a child again with achondroplasia. But sometimes it may happen that the husband and wife both have achondroplasia, which sometimes really happens because they both are short and tend to marry with each other. And here you can see the risk of having a child with achondroplasia or possibility is 50%, but they can have a normal child as well. And some of them, 1 in 4 possibilities that they mutated copy of achondroplasia gene is passed on from the father as well as the mother, and such an offspring who is homozygous for achondroplasia gene will have a severe type of skeletal dysplasia, which is usually lethal during neonatal period. Then, as I said, if achondroplasia, if both parents are normal and the penetrance is not never incomplete for achondroplasia, then if there is a one child with achondroplasia, the possibility that the next child can have achondroplasia should be almost negligible or should not happen because it will happen just again by de novo mutation. But it is observed that the possibility that the second child will have achondroplasia, even if both the parents are normal, is 1 in 400. And that is because either of the parents may have some level of mosaicism or some level of cells in the gonads with achondroplasia mutation. And hence it is important that you do DNA-based diagnosis for achondroplasia in every case, and then probably if the family wishes, they can be provided prenatal diagnosis based on this particular DNA mutation. And it is very easy because almost 98% of all achondroplasia patients have the same G2A change in FGFR3 gene, and it's very easy to test for one nucleotide change, and it needs a very simple test of Sanger sequencing, and then prenatal diagnosis can be provided. Ultrasound based prenatal diagnosis achondroplasia is not possible during first few weeks of our first or second trimester because the shortening of limbs usually manifests in the third trimester. So, if by chance, if the fetus has at third trimester is found to have small short forearm, short limbs, especially femora, you can again test the fetus also for this particular DNA variation, which is the cause. And then if it is achondroplasia, but sometimes there are many different causes of short femora, and so achondroplasia being one of them. This particular famous dancer has achondroplasia, and then everybody with the same type of features will have the same mutation, as I said. The photograph which I have shown is a severe type of skeletal dysplasia caused by mutations other than this mutation, and these are very severe variety, and this is called thanatophoric dysplasia, which is then naturally allelic to the disease achondroplasia because it is also caused by the mutations in FGFR3 gene. Coming to the recessive disorders, thalassemia major is a very classical disease of prototype of autosomal recessive disorder. And these three children, these are iconic picture and of my career where the treatment of thalassemia was difficult and they had to pay. The mother was single mother with three affected children and one of after other they died because she could not afford treatment. Though treatment was possible at that time because of with hypertransfusion therapy. So the risk of recurrence after birth of one child with autosomal recessive disorder should be 1 in 4 or 25%. Then why three affected siblings? It's because chance does not have memory and the possibility that all three consecutive children will have the same autosomal recessive disease would be 1 in 64. That means if there are 64 couples where both are carriers of an autosomal recessive disorder, one of them may have three consecutive children with the same serious type of autosomal recessive disorder. And hence, if the disorder is severe enough, they would need prenatal diagnosis for every pregnancy of the mother, even if previous one or two children are normal. Uh, as contrast to this picture, now these are my young friends with thalassemia, and they are doing so well because of the good therapy they are getting from their young childhood. And now government also provides free of cost care for their transfusions as well as their ancillary drugs. And they are successful entrepreneurs, educated and taking care of their own health and life very well. So it's important to know that the disorders of genetic disorders over years are getting good therapies, and sometimes we wonder whether like prenatal diagnosis and prevention by screening everybody, whether it is justified or not, because it's become a very good, easily treatable disorder. Now even gene therapy is possible for beta thalassemia major. But if a family has one child with beta thalassemia major, and they naturally would want that the second child should not have the disease, then during next pregnancy, if you have to provide prenatal diagnosis, you have to know the mutations in the child. And when though we called homozygous, basically most of the children with thalassemia major have two different mutations. One inherited from father may be different, and the other inherited from the mother, which is a deletion in this case, may be different. So basically, these are compound heterozygotes at molecular level. That means both copies are mutated. You can call them homozygous, but basically, in truly speaking, they are carrying two different DNA variations and two copies of the beta globin gene and called beta compound heterozygotes. Family with sickle cell disease. Now, as I said, it's also allelic disorder to beta thalassemia and also again recessive disorder. So in this case, you see that in addition to the children, the mother is also affected. So why should her children should be only carriers, but why does she have affected children? And it looks like a dominant disorder. And this is because sickle cell disease is quite common. In many populations, there are many sickle cell carriers. And though her husband is not her blood relative, he may be carrier of a sickle cell disease, or sometimes with consanguinity, the possibility of the spouse becoming carrier of the same autosomal recessive disease increases. And superficially, such family of autosomal recessive diseases may look like autosomal dominant disorder, where the mode of inheritance, like the affected persons, are present in different generations. So this is called as pseudodominance, and when you analyze a pedigree, you should be aware of these type of basic principles of medical genetics so that the pedigree can be properly interpreted. Now, in this case, both the couple, both partners are having sickle cell disease. So, their two children have sickle cell disease. What is the possibility? The third child also will definitely have sickle cell disease. So, what are the options for them? Because if you do prenatal diagnosis, you know that a fetus will be affected in 100%. The possibility is 100%. So, in that situation, one may consider the possibility of a gamete donor like sperm donor or IVF with ova donor. But also you have to know that the family, both of them are living probably good life with sickle cell disease, and they might not have severe illnesses till now. Their two children are getting good therapy with, say, hydroxyurea. They may not be worried about having another child with sickle cell disease. So you have to know that these, while offering such type of options like ovum donation or sperm donation, the possibility, what the family feels about the disease and what are their options or their decisions, you have to be aware that they may not want such type of ova donation, or they may live with the sickle cell disease and take good care of their children. When we think of autosomal recessive disease, always a word comes to my mind is consanguinity. So consanguineous matings means the partners are blood relatives. So they may have a common ancestor at the most at the level of great grandfather. So some common ancestor in the sixth generation is called consanguinity. And because in such situation, if one of the common ancestors have some disease causing mutation of autosomal recessive disease, usually a rare type, it may pass on to the following generations, and then somewhere, if there is a consanguineous mating, both of the partners may be having the same mutated allele, and then the possibility that they may have affected children. So autosomal recessive diseases, there may be the history of consanguinity in their family, but also you have to remember that in many consanguineous families they have normal children, and many of the children are normal. Not that if there is a consanguinity, the risk of having autosomal recessive disease is very high. It is just increased by 2 times at the most as compared to the general population without any consanguineous marriages. But as what I told you, that the serious recessive disorders may occur in consanguineous as well as non-consanguineous marriages. But what we have observed, that if there is a rare genetic disorder, the possibility that the parents may be consanguineous increases as compared to the common or more common autosomal recessive disorders like thalassemia. But again, to remind that many non-consanguineous families can also have rare autosomal recessive severe disorders, serious disorders, and avoiding consanguinity is not the only option, and it will not prevent serious autosomal recessive disorders. They will continue to happen. So in this situation, there is consanguinity, and you see that there are two affected children, but it is not autosomal recessive disease. And here, what we see is that both of them are having Down syndrome or trisomy 21. So it is very important to you examine the child, and so that you can make interpretation about the pedigree correctly. Many such serious or many such autosomal recessive disorders which are not diagnosed anywhere, like these type of birth defects in a family we saw, and in a nuclear family, but the parents were consanguineous. So there was recurrence. This girl was, we had seen, and then the recurrence in the fetus, and naturally once we did exome sequencing, we could identify that this particular extremely rare birth defect, not reported in anybody else other than this particular family, was due to sequence variations, pathogenic sequence variations in BHLHA9 gene. So the point to stress it with NGS era, or even for a good astute clinician, the boundaries between research and patient care are getting blurred. So these type of rare disorders, once you identify and report, they get reported or included in a database of genetic disorders. It's called online Mendelian inheritance in man. And when you keep on seeing update, so they keep on updating if there is new information for that particular disorder. So OMIM is a good source for information about genes and genetic disorders. So such type of rare genetic disorders before the era of next generation sequencing, where we were reporting, and this is another family with 3 children with polydactyly and intellectual disability. We reported it somewhere long ago, maybe in 2000. And then probably after 15 years, we could identify the causative gene when the children have grown up. Another family which was reported by us as a overlap between orofaciodigital syndrome and Ellis-Van Creveld syndrome. We could identify a gene in a ciliopathy group of genes, which is a novel gene for this particular phenotype. Now coming to the X-linked recessive inheritance, hemophilia is the prototype, and this particular famous family where the hemophilia was transmitted in the royal family. Now we know that hemophilia is a X-linked recessive disorder, and you can see these famous people in this particular pedigree, where you can see Diana here. So now over this generation, this hemophilia gene is not there in this particular royal family. Other disorder, X-linked recessive disorder, is a Fragile X syndrome. Other is Duchenne muscular dystrophy. So the mutation testing for these disorders is different. Duchenne muscular dystrophy is different, Fragile X syndrome is different, and even hemophilia, it's an inversion mutation which may not be picked up by exome sequencing. So when you draw a pedigree and make your diagnosis, so in this family you can see males affected connected through females who are obligate carriers. So if you suspect Fragile X syndrome, then you have to order a specific test for Fragile X syndrome, which is not exome sequencing, but you have to mention that you want to look for this triplet repeat disorder by triplet prime PCR. We have seen modes of inheritance, common typical modes of inheritance, dominant, recessive, and X-linked disorders. So the other X-linked disorder is Duchenne muscular dystrophy. Everybody affected with a very classical phenotype. So even without seeing a patient, we can know that this is Duchenne muscular dystrophy. Now this girl wants, this sister wants that whether their children will be having this disease or not. So the most important point is that we have to identify disease-causing mutation on DMD gene. And here none of the affected persons are available, neither their samples available. So the question is whom to test. One important thing is the mother, the 65-year-old mother, or the mother of this the other boy who is also not alive. If we can test them, they are obligate carriers. So if we can test them, then we know that what is the mutation in this family, and then we can test the same mutation in these particular sisters. But sometimes it may happen that this 65-year-old lady is far away, refuses to give blood transfusion. Then what we did, we tested all three of them. And then it is a test called multiplex ligation prime PCR. So when we see their results. So sister 1, she does not have any deletion duplication in DMD gene. So we don't know whether she is a carrier or not, because the mutation may be different. But sisters 2 had deletion of exons 3 to 30. So now we know this is the disease causing variation or mutation in this particular family, and this is absent in sister 1, so she is not carrier for Duchenne muscular dystrophy. So you can use such type of information when the proband or any affected child is not alive. What we were talking about was mainly diagnosis and then genetic counseling and prevention by recurrence if the disease is severe. But some diseases now you can also be treatable, and then you can see that prenatal diagnosis can help in treatment. So this is an X-linked anhydrotic ectodermal dysplasia. Many pediatricians commonly diagnose easy diagnosis because they get fever, they cannot sweat, they do not have teeth, and their hair are sparse. So for this particular disease, the scientists have identified a therapy. They can give that deficient protein in the amniotic cavity. And in this mice, you can see this is a mouse model of this particular ectodermal dysplasia. And this mouse was treated, second mouse was treated by intra-amniotic infusion of the deficient protein, and it has normal skin coat as well as normal sweat glands. And the same thing was tried in human beings, and you can see the younger twins, because they were treated by prenatal amniotic infusion of the deficient protein, they could be they do not have the disease manifestations, though they have the causative mutation. But such type of novel treatments really are very, very earth-shaking and are very important for the family to know, though many times the cost of these newer treatments are beyond reach of many people. But for hemophilia, the scenario is changed. So this is a typical family, in fact, real family of this hemophilia. And you can see on one side, the mother with two children with hemophilia, one died, other is handicapped because of chronic joint arthropathy, and his sisters, they say that they want prenatal diagnosis for hemophilia and they would want carrier testing. So here again, the question is you have to first test the affected son. And there are two affected boys in this family who can be tested, and they can be provided carrier screening to this couple. On the other hand, the third generation first individual girl, she is obligate carrier because she has a son with hemophilia who is 6 year old. She said that she does not want prenatal diagnosis during next pregnancy because her son is getting a long-acting prophylactic therapy with a drug called emicizumab and sub one injection during a month, and then he can forget that he has hemophilia. Such effective therapy, she has seen her son is doing so well, so she feels that she would not like to do prenatal diagnosis during next pregnancy. If the child is affected, she will treat. If it is not affected, that's very fine. So the point to tell is that everybody can have different experience of the disease. Their perspective may be different, and their needs regarding prenatal diagnosis or decisions regarding terminations may be different. So basically, counseling has to be non-directive. You don't try to become patient yourself. Like in this picture by Isher, the artist and the picture are the big same. But here with patients, you have to provide them appropriate information, and then they can take their own decisions regarding reproductive planning. In this case, again, just an exercise to learn that this particular lady wants carrier testing. So would you like to do carrier testing for hemophilia? It's a severe hemophilia in this family. These two affected children have a value less than 1%, while her father never had any bleeding. So it means that father is unaffected, and if you can test and his factor VIII level will be normal, so we know that she is unlikely to be carrier and she doesn't need genetic testing. On the contrary, if he is affected, then a possibility that she will be carrier is 100%, because he has only one X. The man always has only one X, and that one has hemophilia mutation. The girl will receive the same X, daughter will receive the same X from the father, and then she will be always carrier. So if he is not alive, still you can test her and find out the DNA mutation, because she is a obligate carrier. Now going to the other type of X-linked disorder. So this is a Fragile X syndrome. And here again the father is unaffected and the daughter wants to know whether how to get Fragile X screening test done, because she doesn't want a child with Fragile X syndrome. So in this case, though the father is unaffected, the genetics of Fragile X syndrome is little different. Some individuals have what is called as a premutation and not mutation. But that premutation carriers, man can transmit that premutation to the daughter, and then her children can have a mutation and the disease. So her father is normal does not mean guarantee or that she will not be carrier of Fragile X syndrome. So depending on the disease, the genetics may vary. And if you have to find out about those genetics, you can really go to the website OMIM and find out about genetics of that particular disorder. So again, to stress, anybody who wants to learn about genetics or has a patient with genetic disorder, you have to visit OMIM to get updated information. Now coming to the another important, everybody keeps on sending exome sequencing. So exome sequencing is sequencing of all coding regions in the genome. So here the diagrammatic picture shows all coding regions and nearby non-coding regions. So exon intron boundaries are seen. So this is used for many disorders where there are many causative genes like retinitis pigmentosa, or maybe more than 40 genes, intellectual disability. You cannot get any clue from that examining the patient, and the causative gene may be anywhere in the 15,000 genes. So exome sequencing is a very powerful technique for all of clinical geneticists, and it can give diagnosis in many of those cases. So how to interpret those results? I would give importance of pedigree into that, and we have to apply the principles of genetics. Like if in this case there is no consanguinity, parents are normal, and the boy or the son is affected. The mode of inheritance can be any. It can be X-linked recessive, it can be autosomal dominant. But if you get an information that the parents are consanguineously married, the possibility that the disorder could be autosomal recessive increases, and then you can accordingly interpret the exome results or provide them information. So this is like one where here the possibility, if you think that it could be a dominant disorder, then the parents are unaffected. The child, the person affected person should have a de novo mutation. But here you see that if you only test the child, there are two variations on a gene, and you may feel that this is likely to be causative. So in that situation, the father and mother have to be heterozygote for this, and this supports that this could be the causative gene for this particular disorder. While in this case, if you find that the child has three variations, and we see that uh, so In the previous case, if we feel that this is a autosomal recessive disorder because they are one copy is inherited from both of the parents, but sometimes what happens that the one of the parents has both copies with the same variation, then it obviously means this is not disease causing variation because father is also homozygous for that variation. While if you get three variations in an individual, one is wild and other two are the disease, probably different. They are not normal. So in that situation, if you decide blue is from one of the parent, red is another from the parent, and both copies are mutated, so this could be the cause of disease in this particular boy. But sometimes it happens both the mutate so-called variations which may be disease causing are present in one of the parent, and it means that these two variations are not cause of this particular disease. The point to stress that this pedigree information is useful in interpreting the exome data, and that's why you should always send trio exomes. That means the exomes of the father, mother and the child together, usually if the cost is not a constraint, especially in prenatal diagnosis. In case of autosomal dominant, if you see that father and son are affected, then both of them should have the disease causing variation reported by red. But if the variant is not disease causing, and the normal father also has, then probably either this is not disease causing, because here both parents are normal, then the disease causing variation should be present only in the son, but here you can see it is also present in the father. So you have to examine the father carefully if he has some features of that particular disorder, or we can interpret that probably this variation is not disease causing. So again, all these points are to stress that trioexome is important for interpretation. Like here, both parents have wild type of allele, while only one variation in the son, and then this type of de novo variation or de novo mutation can be causative. So such type of interpretation are very, very important. So again, to stress that even if it is in the era of next generation sequencing, you have to draw a complete pedigree, and your pedigrees may not be that interesting like the pedigrees of these beautiful women, but they can provide a very important clues to the mode of inheritance, to the diagnosis, or sometimes about who are possible carriers, who are obligate carriers, and sometimes they are very, very precious for interpretation of the DNA variants identified by exome sequencing. So it's important to draw a pedigree, think with a genetics perspective, and uh, interpret the exome data very carefully. Every variations which has found in the DNA sequencing by exome sequencing, this may not be harmful. Every one of us have thousands of variations which are responsible for our variable looks as well as variable body physiology. Same way, anything what you, and then many of those even so-called diseases, the individuals those with those disorders live so successful and good life that every variation need not be terminated. If you see ultrasonographically any finger abnormalities and terminate it, you may lose a very, very talented human beings from coming to the world. So draw the pedigree of each case, get the proband evaluated, and order the test only if you can interpret the results or deal with the results, explain the results to the family, because such type of multi-targeted exome sequencing data, they may provide solutions, but they also can sometimes create dilemmas. So those who have proper knowledge about genetics and exome sequencing should only order exome sequencing data. Otherwise, with the results, you may be into more problems, and not only you, but especially with fetal exomes, the family may have to pose new dilemmas, and it should not happen that the pregnancies are terminated without enough evidence of pathogenicity of that particular variation. Again, coming back to thalassemia, you cannot, this is a big party where I have so many friends, and many of them I have, they are thalassemia warriors, very successful individuals, much stronger than me. And we really, you cannot find out who are the patients amongst them. And I don't like to call them patients at all. So again, to say the times have changed, and now the thalassemia is such a treatable disorder with good outcome that one really wonders whether it's really you want to eliminate such beautiful individuals from coming to the life. So think with Indian perspective, think about exome sequencing, but be careful. Otherwise, you will want to you help the patient, but you may end up in creating new dilemmas for the family. So better to understand principles of genetics and molecular vocabulary so that you can help the family. Otherwise, I would like to say, by exome sequencing, it should not happen that जाना था जापान पहुंच गए चीन समझ गए ना. Thank you very much.